Hello everyone, this is Dr. Madhusudan Rao on the program I teach medical students. In today's class, I'm going to touch briefly on the sixth cranial nerve, that is abducens nerve. Abducens nerve is a purely motor cranial nerve that innervates the lateral rectus. Its nucleus is located in the upper pons, dorsomedial aspect, just ventral to the or in the floor of the fourth ventricle. The nucleus of the abducens nerve is looped by the fibers of the facial nerve, which courses from medial to lateral side, looping the nucleus of the abducens nerve. Well, we are going to cover this topic with regard to the anatomical considerations of the abducens nerve and its clinical importance. Sixth cranial nerve is purely motor cranial nerve, which I told you, supplying the lateral rectus. The point of importance of this nerve is it has got long intracranial course, liable for injury due to raised intracranial tension. Why should the nerve be injured due to raised intracranial tension? During its course, the nerve passes under the bony part, that is petrous part of the temporal bone. In case of raised intracranial tension, bone is pushed down and the nerve is injured due to traction. This traction injury causes the paralysis of the sixth cranial nerve, presenting as a false localizing sign. Because the lesion is somewhere due to the cause of raised intracranial tension, and the absence now presents as the isolated cranial nerve palsy without any other findings related to the long tracks. So this is considered as a false localizing sign. We are going to touch that in the course of time. Well, the nucleus of the abducens now receives its supranuclear fibers from the motor cortex of both the hemispheres. Okay. It also receives its afferents from the contralateral parapontine reticular formation. This is a cluster of nuclei that controls the horizontal gaze. This is considered to be the pontine center for horizontal gaze. Okay. In turn, the abducens now, after receiving the fibers from the parapontine reticular formation from the contralateral side, it sends its efferents crossing to the opposite side, which ascend into the medial lemniscus to innervate the oculomotor nerve. Thus, the abducens now controls the abduction of the ipsilateral eye due to its innervation of lateral rectus, and it also controls the adduction of the contralateral eye as it innervates the third cranial nerve. As I told you, through the parapontine reticular formation. So the abducens nerve is responsible for, in coordination with the PPRF, for the horizontal gaze. That is ipsilateral horizontal gaze. Okay, this we are going to discuss in the clinical features or the clinical applications of the lesions of the sixth nerve when we are talking about the gaze paralysis. Then the efferents from the abducens nerve nucleus, the axons from the cell bodies located in the nucleus of the abducens nerve, they descend down in close proximity with the corticospinal fibers to the point of pontomedullary junction. From this point, the fibers of the sixth nerve exit to enter the intracranial course. Okay, from the point of pontomedullary junction till it exits from the superior arterial fissure, it is the long intracranial course. So the fibers from the point of pontomedullary junction, they ascend upwards. Okay. Okay. From there, it passes on the petrous part of the temporal bone, enters the Dorolo's canal, then finally reaches the lateral wall of the cavernous sinus. In the cavernous sinus, it is accompanied by third cranial nerve and the fourth cranial nerve. So ultimately, it is going to exit from the superior arterial fissure, enter the orbit, and finally innervate the lateral rectus. So this is the course of the abducens now from its origin at the nucleus in the upper part of the pons, in its medial part, and it can be injured from the point of its origin in the nucleus to the point of its entry into the orbit. Okay. Well, blood supply. It is from the branches of the basilar artery. Basilar artery gives away its paramedian branches and the perforating branches, which supplies the pons. Vascular lesion, trauma, neoplasms, or infections could be the causes of sixth nerve palsy. There is one syndrome described as the Wernicke-Korsakoff syndrome. It's caused by the thiamine deficiency in patients with chronic alcoholism. And its features are characterized by the absence of palsy, progressive dementia, cerebellar signs, and ophthalmoplegia. Well, clinical manifestations of sixth nerve palsy are described in the term sixth syndrome, which we are going to touch in detail. Sixth syndrome includes, number 1, brainstem syndrome. Number 2, raised intracranial pressure syndrome. Number 3, petrous apex syndrome. Number 4, cavernous sinus syndrome. And number 5 is orbital syndrome. Okay. Coming to the brainstem syndrome. What are the lesions? It could be vascular. Okay. Vascular lesions secondary to the obstruction as a part of the obstructive stroke, most common. And it could be tumors. Well, it could be infections like meningitis, or neurocysticercosis, or tuberculosis, etc. Or it could be trauma. The brainstem syndromes are described based on the extent of the lesion, okay, which will manifest with a different spectrum of clinical manifestations. These syndromes are 1, Raymond syndrome. The lesion is in the ventromedial pons. Okay, its features are ipsilateral sixth nerve palsy and contralateral spastic hemiplegia. Next, Millet-Gobler syndrome. The lesion is in the ventromedial pons. Okay, little more extensive. It involves the fibers of the abducens nerve. In addition to that, exiting fibers of the facial nerve are also affected. Okay, so It presents with the ipsilateral absence nerve palsy, ipsilateral lower motor neuron type of facial nerve palsy, and contralateral hemiplegia. That is Miller-Gobler syndrome. Then Foville syndrome. It is characterized by little more extensive lesion, which presents with the ipsilateral absence palsy, ipsilateral facial nerve palsy, also involves the PPRF, resulting in ipsilateral horizontal gaze paralysis. Okay. And if the lesion is some more extensive, it affects the ipsilateral fifth nerve as well as ipsilateral seventh nerve and ipsilateral Horner syndrome, and associated with contralateral hemiplegia. So Foville syndrome is associated with a little more extensive lesion, okay, involving the nuclei of the absence nerve, facial nerve, and trigeminal nerve, and sympathetic chain, okay, and also PPRF, presenting with the spectrum of manifestations described earlier. This is Foville syndrome. Let us see some of the pictures. This is a common Raymond syndrome. The lesion is somewhere in the ventromedial part of the pons. This is the lesion. Okay. It is involving the fibers of the sixth nerve. These are the fibers of the sixth nerve, which extend from the nucleus downwards. They run in close proximity with the pyramidal fibers. So when the lesion involves the ventral medial part of the pons, it results in Raymond syndrome, characterized by ipsilateral sixth nerve palsy and contralateral hemiplegia. Next is the Miller-Gobler syndrome. In this picture, you see the file photos of the scientists Miller and the Gobler. The lesion is more anterior than the Foville, spares the absence nucleus, but affects the fascicles of the sixth nerve, characterized by ipsilateral peripheral seventh nerve and ipsilateral lateral rectus palsy and contralateral hemiplegia. This I have touched already. This is the picture showing the file photo of the Foville. Foville has described the syndrome. The lesion in the dorsal pontine, okay, dorsal pontine tegmentum in caudal third. The lesion being in the basilar artery perforating branches. It's characterized by ipsilateral facial nerve palsy, ipsilateral gaze paralysis, horizontal gaze paralysis, contralateral hemiplegia. Okay. So these are the features of Foville syndrome. Sometimes the lesion could be a little more extensive, resulting in the ipsilateral Horner syndrome. So this is the picture showing the lesion in the Foville syndrome. Then coming to the raised intracranial pressure syndrome. The lesions are any lesion that is associated with the raised intracranial pressure. It could be cerebral hemorrhage, it could be cerebral edema, it could be pseudotumor cerebri. What is pseudotumor cerebri? It is a situation wherein there is a papilledema with normal ventricular size, with other ocular signs. There could be intracranial space occupying lesions or any type of hydrocephalus can result in raised intracranial pressure. Well, this nerve is injured because of its long intracranial course, as it is passing through the Doralus canal in the petrous part of the temporal bone. During the situation with raised intracranial tension, brain is pushed down. That results in the traction injury to this tiny nerve, resulting in sixth nerve palsy, described as a false localizing sign. So it may present with the features of the primary lesion, features of raised intracranial tension in the form of the headache, vomiting, bradycardia, visual disturbances. It is isolated sixth nerve palsy. There is no involvement of the long tracts. Remember this. And it occurs in situations like in 25 or 20% of the cases are in pseudotumoral cerebri, which is described as the presence of papilledema with normal ventricular size. Next is Petrus apex syndrome. The lesion could be trauma, could be infections, could be otitis media. The nerve is affected when it is passing through the Doral's canal. The presentation will be features of the local infection like otitis media and ipsilateral sixth nerve palsy. Sometimes there could be involvement of the ipsilateral, trigeminal, facial, and vestibulocochlear nerves. When these cranial nerves involve, it mimics cerebellopontine angle syndrome. But the difference is, in this particular syndrome, there is no involvement of long tracts. Okay? This has to be remembered. Because it is purely extracranial lesion, extracerebral lesion. So it does not affect the long tracts. Cavernous sinus syndrome. The lesion is in the cavernous sinus. Okay. It could be due to nasopharyngeal carcinoma, could be carotid aneurysm, could be carotid cavernous fistula, or could be meningioma. Okay. It is associated with the ipsilateral sixth nerve palsy, also involving the oculomotor and trochlear nerves. Okay. It also affects the sympathetic plexus, right? Yeah. Then orbital syndrome. The lesion is in the orbit secondary to the infection, and patients present with painful eye, which is swollen, congested, associated with proptosis, and ipsilateral sixth nerve palsy. Okay. Well, lastly, coming to gaze paralysis. Gaze paralysis is nothing but disturbed conjugate eye movements. Conjugate eye movements are characterized by one eye following the direction of movement of the other eye. Okay. When the left eye is moving to the left side, right eye follows it. It also moves towards the left side. This is in order to maintain the parallelity of the vision. Okay. So these eyes are really fronts to each other. One eye follows the other, but they never look to each other. What happens if they look to each other? Okay, it results in blurring of the vision, sometimes diplopia. Well, gaze paralysis occurs because of the lesions in the lesions in the center for conjugate eyeball movements. Okay, you have got the frontal eye field as the cortical center for gaze paralysis, and you have got the pontine center for the gaze paralysis. Cortical center for gaze paralysis is located in the frontal eye field. Okay, it controls the contralateral conjugate eye movements. Okay, when the lesion occurs involving the frontal eye field, it results in the paralysis of the contralateral horizontal gaze, and the patient looks towards the side of the lesion because of the unopposite action of the opposite frontal eye field. Whereas pontine center for gaze paralysis is located in the PPRF. Its relation results in the ipsilateral horizontal gauge paralysis. Okay, it is in association with the abducens now nucleus. Okay, well, there is no diplopia in gauge paralysis. Remember this point. Yes. Well, thank you very much for patient listening. Hope you have understood the anatomical as well as the clinical significance of absence now. Thank you again for patient listening. We'll see you later in the next class. Until that time, bye-bye. Thank you.